Well, appreciate this opportunity to have the chat with you all, and yeah, fire away with the questions as they come up. Want to keep this very conversational. Just a little bit about me and about SolV. I've been doing this 35 years. I already gave away my age, so all about that. But had my first brokerage started in 1992, Kelley and Swain. In 2008, we sold up to a startup, Epic, and we were the employee benefits platform for them. Was there until 2016 when I decided that there's a better way to do this than others were doing it. And that's when we started SolV in 2016. And within 3 years of business, we qualified for the fastest growing companies in the Sacramento area. And we actually, out of the top 50, we got number one on that list that year. And I think that's just because of our approach of trying to bring more transparency, not only with the vendors that we promote with our clients, but also with the way we approach our clients and with our own services. And I think, that's one of the big problems in our industry. And that's one of the things I love about RBP is the transparency that it brings to the client. And we just talked to a prospective client yesterday, about 1,000 employees, and they've been with Aetna for 10 plus years. And his big thing was, it's like a black box. I don't know. Aetna tells me here's the bill charges, and they tell me here are these great discounts that they're receiving, but they don't give me any kind of an objective reference. And we have those kind of conversations all the time. So I wanted to just kind of go over a few slides and talk about the broken healthcare system, and then we can jump into kind of the theme for the call today, which is RBP realities, avoiding common mistakes. So we all know the problems. This slide changes a little bit year after year. This year, when I looked up the stats on the Kaiser survey, health insurance cost increases were 52% and employee contributions 52%. So they lined up this year, which I guess that means employers are more and more passing on exactly their increase to their employees. 66.5% of personal bankruptcies are now related to medical debt, and 41% of Americans have healthcare debt. And it seemed like that was like 33% last year. So the system is broken. We talk to a couple hundred prospective clients a year at SolV, and we start those conversations with kind of talking about the brokenness of the system. So what we're going to talk about today is RBP and the hospital piece of that. But quickly, I just want to talk about the overall brokenness of the system. So you've got, hospitals, these numbers change every year, but in Nevada, the average bill charge is now 1,200% of Medicare. So they're the poster child for the most egregious billing charges above Medicare. But a lot of states are at least 400 to 600% above Medicare. And it seems like it was only 5 years ago that the BUCAs, Blue Cross, United, Cigna, Aetna, their discounts were putting their reimbursements at about 250% of Medicare. And now that's north of 300% of Medicare on average. So that's very broken, and that's where RBP can help a client out. These other pieces of the broken system I'll touch on very quickly. Big pharma is really broken. In the hospital space, typically we're able to save clients, 30% to sometimes up to 50% on their hospital claims through RBP. In the pharmacy space, because of the brokenness of big pharma, we're able to save clients 55 to 65% when they come from Blue Cross, United, Cigna, Aetna. Insurance companies, I stole a slide from Scotty Campbell that a lot of you know him, but this is his fully insured cartel slide that just shows the increase in stock prices for the major carriers versus the S&P 500. So since the ACA was passed, the insurance carriers are doing really well, and that's because of MLR, medical loss ratio. The only way, we'll pick on Cigna since they're on the top of the list here, the only way for Cigna to make more money is if premiums go up. So Cigna has no interest in premiums go down, because if premiums go down, they actually make less profit. And then the next kind of piece of the broken system is the brokerage community. That's us. Those large insurance carriers paying overrides. Sometimes those overrides are disclosed to clients. They're also called contingency commissions. Sometimes they're not. But they incentivize brokers to keep their business with Blue Cross, United, Cigna, Aetna. So that's a big problem in the system. And a lot of our people here at SolV have come from large national brokerages. And several of us have been told at our large national brokerage, we don't want you to move this client off of United Healthcare. We'll pick on United Healthcare this time because it's going to mean a loss of revenue to the brokerage. And then the last piece of the broken system is the politicians. I talk to prospective clients who say, I think the government's going to come in and help us out. But 40% of the lobbying dollars in the U.S. come from the healthcare industry, all these bad players. And so, neither side of the aisle is really interested in solving the real problems in our broken system. So let's jump into RBP and that discussion. And just, for those of you that are on the call that maybe don't have as much experience with RBP, I just wanted to give kind of a quick overview of, what we see our clients experience. Many of those clients before working with us, they came from Blue Cross, United, Cigna, Aetna, a Buca carrier. And they were experiencing top-down pricing. So bill charge, Aetna's negotiated discount, and here's what the client pays. And again, that black box that prospective client talked about yesterday, and not really understanding what is my pricing from an objective standpoint, what am I paying for my claims? And then when they move into RBP, it becomes a bottom-up pricing. And the cost of reference that most RBP vendors use is Medicare. So when a client moves from that top-down pricing to Medicare Plus, most of our clients do Medicare Plus 40%. And when they do that, 95% of those hospitals do not push back. About 5% do. Most of our clients have elected when a hospital does push back to pay them a higher amount until that's settled. So most of our clients end up paying on average 152% to 154% of Medicare versus their prior Buca carrier at 300% of Medicare. And so I wanted to also just quickly give a real life claims example. So this is a client that had a heart attack claim. This client moved from Blue Shield of California to RBP. This PPO discount for this heart attack, the bill charge was $48,000. The PPO discount would have brought that down to $21,000. And so this is what a lot of clients are looking at when they're working with Buca carriers is what is that discount? And that looks pretty good, right? The Blue Shield lowered it from $48,000 to $21,000. But when we moved this client into RBP, this claim actually got paid at $11,000, so almost half of what it would have been paid at with a PPO discount. So that's why our clients are moving in this direction. I'm gonna next just quickly mention these are some of the vendors in the RBP space that SolV has worked with our clients. So we have worked with a lot of different vendors out there and see a big difference in their approaches. And now I'm going to jump into the theme of today's call, which is pitfalls of RBP in the real world. And again, feel free to pipe into Heath with questions if you have them in the chat, and I'll answer those as he shares those with me. So first thing is the wrong broker consultant. And this happens often. We talk to a prospective client and they've been with their broker consultant, 10 years, 15 years, and their broker consultant has never talked to them about any of these strategies. But they like their broker consultant and they've been working with them a long time. They have a strong relationship with them and they really trust them a lot of times. So often they will go back to their broker consultant and say, hey, what about this thing I heard about called RBP? And the broker will call a third-party administrator who will bring in some kind of a packaged approach and be the so-called expert at that. And the broker consultant is trying to figure it out. And we've had several of those prospective clients that did that with their broker, basically implemented the approach that we brought to them. And then a year later, they're looking for a new broker because they've fallen on their face because their broker consultant didn't really understand what they were getting into. What often happens as well is that client will go back to Blue Cross, United, Cigna, Aetna because their employees are having such a bad experience. So it's important to choose the right broker. And in another couple of slides, the next couple of slides, we'll talk about what that looks like. Next kind of pitfall is having the wrong RBP vendor. And this is this has been an evolving marketplace in terms of RBP vendors, really over the last 15 years. And as we've seen the market kind of mature, the issue that the early on issue with RBP was balance bills. But that issue has really gone away pretty dramatically. And, our clients working with any of those vendors on that prior slide, they have very few balance billing issues. And what's kind of more the issue these days, I'd say over the last, 3, 4 years with clients, is provider access. So there's some different approaches to provider access, and different vendors take different approaches, all the way from, full RBP, where you're doing RBP at the hospital and also at the physician level, to implementing a physician-only network, or direct contracting, or a hybrid approach where we're kind of bringing them all to the table. So, and there's pros and cons with those different approaches, but it's important to choose an RBP vendor that really understands that their approach is really working. For example, one of those vendors, their PPO network, their physician-only network, on the urgent care side, that network is primarily a workers' compensation network, and that network that they contracted with for urgent care, they prioritize occupational health above people that come in for urgent care needs. So our clients that were working with that vendor, they weren't having a lot of issues on the physician side, but that when their employees went into urgent care, and this was down in Southern California, a large metropolitan marketplace, they were being put to the back of the line, and they were having a lot of issues with urgent care. So that's just one example of things to be aware of that can happen if your vendor is not working with the right network. Another thing that we see is this kind of move towards consolidation. So historically, a client chooses an RBP vendor, they choose a third-party administrator, they choose a PBM, they kind of bring all those pieces together through the broker consultant. Or if the broker consultant isn't as familiar with these strategies, the broker consultant might rely on the TPA to bring all those pieces together. And so what we're seeing in recent years is a few vendors that are coming to the marketplace with a consolidated approach. They're either buying a TPA or buying a PBM, or all three, and putting together this consolidated approach. And some of those vendors have had more success with that than others. But that's something to be careful of when you're chasing the new thing, the new approach, is that the vendors that they're bringing together have a strong track record of providing this kind of service. We had one of those consolidated vendors that decided to purchase their own TPA and badly botched that implementation. And that has gone really, it was really rough for our clients. We had a lot of clients that had to transition away from that vendor. So, something else that we see is either a large insurance carrier purchasing a TPA, or a venture capital firm comes in and purchases one of these RBP vendors, or they purchase this consolidated approach, and that handoff doesn't happen well. We've probably experienced that more on the TPA side, but we've experienced it also with these vendors that are bringing in these bundled approaches. So, just keep an eye on what your vendor is doing in terms of, are they scaling at the right speed? Are they overloading some of their vendors, either the TPA or the RBP vendor? So just something to keep an eye on. And that's why it's important to be working with the right broker consultant who really has the experience with multiple RBP vendors and can be advising you of these pitfalls.
Hey,
Yeah, go ahead,
Scott,
Heath.
on the
Yep.
this is going back a few minutes here in the discussion, but you'd mentioned that the balance bill risk is diminished significantly, which I would agree with. kind of a two-part question. One, what do you think the biggest driver of that is? And then part
Yeah.
two is, are you seeing any differences between the different models that you've worked with, and how does that, uh, I guess, play out in terms of its results versus the expense, or the different variables that would play into it?
Yeah. Let me take the first part of that question, Heath, which is why? Why are we not experiencing as much balance billing? And I think it's because a lot of the large hospital chains, had very aggressive bill collection practices, and they were going after people that they were supposed to be providing free healthcare to under their nonprofit charter, and they got a lot of bad press from that, and they really backed down from that approach. And so this is kind of my perception. I don't know if it's reality, but my perception is a lot of hospitals that we come across, I think we have this feeling that this hospital is very sophisticated and they're taking every charge and they're comparing it to their PPO discount for all of the, various PPOs they work with. But I think a lot of hospitals out there, they're kind of taking the TPA at their word, or the repricing in the way it comes in, and accepting that as that it's complying with some type of a PPO contract. I just don't think these hospitals are that sophisticated. So I think there's a lot of hospitals that just aren't doing any kind of a check to see if their reimbursement matches up to any kind of a contracted discount. So that's kind of my perception of the other issue that's going on. And then the second part of your question, Heath, was are some of these RBP vendors better at it than others? And there's really a variety of approaches, from, we're going to look up hospital cost and we're going to take cost plus, or Medicare plus, and pay something above that. Some of the vendors tell us that they have an algorithm that looks at what a provider has accepted from RBP historically, and they're going to try to make that reimbursement at the lowest level that they can, that the hospital will accept and not balance bill. But they're telling us that that avoids balance billing. So those are a couple of different approaches. I would say most vendors are taking an approach where they're paying Medicare plus, typically Medicare plus 40%, sometimes Medicare plus 60%. And then for those balance bills, then they're negotiating something above that. The other issue is, as we see RBP start to take a foothold in a geographic area, and more of the, especially the large hospital chains or maybe the problem hospitals, pushing back on balance bills, we see the RBP vendors that go and negotiate a direct contract with that hospital. So as RBP matures in a geographic area, you have more and more direct contracting. And there are definitely some RBP vendors that are better at that than others. So that's another reason that it's important to be working with the right broker consultant. Because if you're just trusting the TPA, and the TPA has partnered with ABC RBP company, and they're not the best in your geographic area, and they don't have as many direct contracts, that's really going to hurt you as the client in terms of dealing with more balanced bills. So there definitely is a difference from one vendor to the next. Something that we do to help clients out with that is, when we have a client that's moving from a BUCA network to RBP, we run a disruption report and an acceptance report, and we let them know with the top RBP contenders, here's their RBP acceptance. Not just with the hospitals in the geographic region, but with the hospitals that your employees are actually going to. And that's very helpful. And it's interesting, sometimes when we do that, the RBP acceptance is actually higher than the BUCA network in network, which is really interesting. And a lot of we talk to a lot of clients, and their broker consultant has told them, well, you're gonna face a lot of balance bills. But what they're not telling their client is that their employees are already facing balance bills. Their employees are already dealing with claims that fall out of the network, and they don't have anybody to advocate for them. So in an RBP approach, you've got the RBP vendor to advocate for the member when they deal with a balance bill. And I think another pitfall is a lot of brokers will talk to their clients about, let's pick on Cigna again. Your Cigna in-network payments are 97%, and your Cigna out-of-network payments are the other 3%. But what they're not telling the client is here's how that breaks down on a bill charges basis. So when they're paying based on a fee schedule out of network, that can be a pretty dramatic balance bill. If you start to look at that, I know a lot of you on this call are broker consultants. So if you start to look at that for your clients on a bill charges basis, you might see that 97% in network. When you look at it on bill charges, it's actually 94% of the bill charges that were in network, means 6% of the bill charges were out of network. So for those broker consultants on the call, I encourage you to break it down that way for the client. So great question, Heath.
Yeah. Yeah. One of the points you just made, I used to make a bigger thing about this when I'd have conversations with folks, but there was a Kaiser study and it looked at the balance bill rate on, at the time, I think you had in-network balance bills. That's been somewhat resolved with NSA stuff, but on the out-of-network side, I think Washington was running at 16%. California was pushing, high 20s or something of balance bill rates. And you look at RVP just on facility, let's be fair, I guess, you're in the 5 to 7% range. When you look at a whole block of business, you're getting into the 1.5% range. It's interesting, the optics of it. I think sometimes it's because we bring to light to these plans to make sure everybody's aware if you have one of these things that, to let us know we can manage it for you on your behalf. And so you kind of see a higher rate of it than you probably do otherwise. But good point. But there's some questions that are coming in. I don't know if you want to take those
Yeah.
now or keep going
Yes.
through here. So I
No,
think
that'd be great.
now one of them came in on the chat function. And Linda, I'd encourage you to chat with us. We can talk about what we can do, but I'm going to be fair here and I'll let Scott answer this himself. But it says, thank you for restoring confidence in RBP. As the producer mostly working with small groups in Washington, Allstate Benefits has an RBP product. I believe another producer in my office has a client on that plan. Ultimately, the conference is restored, or at least quote the product. Good to know the balance bill situation is in the rearview mirror. What are some of the questions I should ask my Allstate rep when they provide me an RBP quote?
Yeah, that's a great question. I would first ask, who's the RBP vendor that they're working with? Can they run a disruption report? A lot of our clients that are RBP are above 100 employees and they're self-funded. And they're going out and choosing an RBP vendor independently. So when you're bringing in a packaged approach like the Allstate approach, it's important to look at that disruption if they're willing to run that kind of a report for you. I think the other thing is, looking at the other pieces of the pie. I talked about in my broken healthcare system slide, the broken pharmacy situation. So you want to make sure that you're not, making savings on the RBP program just to give it right back on the prescription approach. So that's where, you really want to look at that prescription drug pricing and how it comes in compared to other PBMs. What's the TPA experience? What's the claims experience? Talking to other competitors about the pros and cons of, in this case, Allstate's approach versus other options for you out there. A lot of times that's better intel than asking Allstate for references, because if you ask them for references, they're going to give you their happiest clients. I'd suggest joining a group like Health Rosetta, where you're able to network with other disruptors, market disruptors like SolV. And you can ask others in your peer group, what has been your experience with Allstate in regard to balance billing or other issues. So that's some feedback that I would have. Heath, do you have anything to add to that?
No, I think that's good. Good advice. I mean, I think you see some variability, you know, market to market. I think one of the mistakes people make is say, I'm located in Washington. How is RVP in Washington? And I would say it's not so much the state you're in. I mean, it can be, if you're in Maryland, for example, that's, a state-based issue, but otherwise it's typically a provider issue. Where's the bulk of your membership going? And that's where that disruption report comes into play. On that report, are you seeing uh, what the RVP stats look like? Or are you seeing what a direct contract looks like? Make sure that's clarified. And then whoever you're working with, what is the standard today may be different tomorrow. You could have the CFO change at a hospital system. And today it's fully accepted, and tomorrow they may, deny care or deny or balance bill, So whoever you're working with, make sure they have the tools in their belt to solve those issues, no matter what comes at them, because it's a pretty constant, variability year to year in terms of how things are need to be managed.
Yeah, that's good. And I think, the issue that I talked about earlier, where a lot of these hospitals are not really comparing what they've been paid back to their contract. I think hospitals are, especially the small regional hospitals, are getting more sophisticated about that. One of my clients is a hospital, and I know they are getting more sophisticated about trying to go back and compare what they've been paid against a PPO network discount and make sure that they're getting paid what they're supposed to get paid under a contractual arrangement. So some of those charges that maybe flew under the radar may not in the future if a hospital upgrades their their software and starts to dig into that a little bit more. We haven't seen that yet, but that may potentially become an issue where they push back a little more.
All right, got another question here. Are you seeing more providers try to collect at the point of service more often, or refusing to grant access without the payment?
Yes. So that's what I mentioned about, balance billing isn't really as much of an issue anymore as access. Um, and that's where, working with an RBP vendor that has a large footprint in the area where your client has employees, that has more direct contracts, um, those that can be a great advantage. Those direct contracts can really alleviate a lot of issues. And there is a significant difference from one RVP vendor to the next. And it can vary pretty significantly by region. So it's important to, take each client and the region that they have employees and look at each vendor in those regions. Again, that's why it's important to be working with the right broker consultant with this kind of experience. But yeah, great question.
And I think, the piggyback on what you just said, this goes back to having all the tools available to you, whether that be leveraging a direct contract, leveraging a contracting team within the organization with those skill sets, or, enough volume that you're pushing through with a very reasonable reimbursement rate that works for that provider. But you've got to be able to move got to move with the flow to make sure that you're getting access to these folks. There's other things that I know that we do, but I think some others do as well, as kind of a prepayment type model that can be administered as well, that can resolve some of those things.
Yeah, that helps a lot. And we've seen quite a difference from client to client in how an RBP vendor approaches a problem hospital. So we have a client that's in a very remote area, and there's one dominant hospital system, as there often is. And the RBP vendor that the client was working with, which we inherited, we didn't actually place that RBP vendor. We dealt with balance billing issues, and this was probably about 6 years ago, 6 or 7 years ago. But we dealt with a balance billing issue with multiple claims over, probably a 3-year time period. and really pushed on the RBP vendor to get in and negotiate a contract with this hospital. And they didn't do it. And ultimately, the client ended up going back to a fully insured carrier. And this was a smaller client. They were only about 90 employees, a little on the small side to self-fund. But they went back to a fully insured arrangement with a Buca carrier because of this balance billing issue. And since that time, we've had clients in that same area with a different RBP vendor that have had virtually no issues. And we have like a 99.5% acceptance rate with the hospitals in that very remote area. And there's about 3 hospitals within about a 150-mile range. And with this different RBP vendor, again, we've got 99.5% acceptance. So that just shows, kind of a real world example of the difference from one RBP vendor to the next.
Excellent. I think we're caught up on the question. So
Okay.
sorry for the disruption. I think you were halfway through the vendor discussion, but they
No,
seem to fit in. They seem to
this
fit
is
in there.
this is a fireside chat, not a monologue.
There you go.
Okay, so charges on a percentage of hospital billed charges while telling me hospital billed charges are the problem with healthcare. So a couple of those vendors on my page, a few pages back, a couple of those vendors, they charge their fees based on hospital billed charges. So when the hospital increases its billed charges by 20%, this RBP vendor gets a 20% fee increase, which makes no sense at all. So that is something to look out for, and something, for those of you on the call that are broker consultants, make sure that you're looking out for your clients in that arena. For those of you that are on the client side, ask your broker consultant, how does this RBP vendor charge their fees, and why do they charge them that way? So most of our clients are with vendors that charge on a PEPM basis, which is more equitable and makes sense since we're all saying that the hospital bill charges are the problem. Why would you charge your fee based on hospital bill charges? The other side of that coin is, at least one of those vendors that we've worked with that does charge on a percentage of bill charges. Because they are making so much revenue, they do provide a really high level of service. They've got a lot of fees coming in the door to fund that. But we've had clients that have been in that kind of an approach and have moved away to an RBP vendor that bills on a PEPM basis, and they've cut their RBP fees in half. And there hasn't been a huge difference in the service level. So that's kind of the pros and cons of that.
Um, on the fee side, do you see stop loss taking any of that into consideration under the different models?
Yes, absolutely. So one of those RBP vendors, and you can all tell I've been really careful not to mention names here, but a lot of you know who I'm talking about. Um, One of those RBP vendors, they bill their fees as a claim. So that comes through as a claim, and then the stop loss carrier has to pay that claim or fee on a large claim. So they will charge more for the stop loss insurance because of that fee that they're going to have to pay. So again, that's another one of those gotchas to look out for, is that you're not paying more for your RBP vendor and also for your stop loss because they're billing on a percentage of hospital billed charges. Good question. Okay, any other questions on that, Heath, before we move on to the next topic
I
here?
don't see.
Okay,
Well, yeah, I don't see any on the screen here. So,
okay. So the next issue I want to talk about is the wrong TPA. And this is really challenging. There's several hundred TPAs in the country and a lot of different approaches. And there's been a lot of TPAs, in the 10 years that I've been doing this, that have kind of discovered RBP and then determined that this is a way to grow their market share. And they've, jumped into it headlong without the ability to scale for that growth. And so they've had success with it. That success has led to more success, and they're not able to scale and keep up with the demand. And they then get overloaded, and then client service suffers. So that's something to be careful of. Something else we have seen is there was one TPA that we were working with, large national TPA. A lot of you'd be familiar with them. And they sold out to a Blue Cross Blue Shield plan. And they had an excellent reputation of service in the RBP space. And once they sold out, their service quickly plummeted. And we had to move several clients away from that third-party administrator. Another issue that we've run into is selling to a venture capital firm. And that venture capital firm is trying to capitalize on the growth in this arena, but doesn't really have the experience or the people that they've partnered with, the third-party administrator that they partner with doesn't have the ability to scale. So just some things to look out for. Again, another reason to make sure you're working with the right broker consultant that has that experience and can help you avoid partnering with the wrong TPA. Okay. Any questions on that, Heath, before I move on?
No.
Okay. So this slide is a little bit about, I keep talking about the right broker partner. So in our experience with the prospective clients that we talk to and what we hear from our Health Rosetta partners, you've got a lot of the brokers out there that take a traditional approach. They offer only fully insured medical programs. Most of their clients are under 50 employees, and they really don't have much experience in self-funding, let alone RBP. Then you've got that broker consultant that we run into a lot, especially in the 100 plus employee space, that they really educate their client on the cons of self-funding. Like, here's all the reasons you shouldn't self-fund. And I probably hear this from a prospective client once every couple of weeks. My broker says I've got large claims and I can't self-fund because I've got large claims. And I always kind of chuckle when I hear that. But if you've got large claims, wouldn't you like to pay a lot less for those large claims? A lot of times they'll use lack of data as an excuse not to self-fund. Like, Aetna won't give us your claims data, therefore you can't self-fund. They maintain, these broker consultants maintain mostly insured business. That's about 20% of the brokers out there. The next kind of category is what we call the easy button brokers, the 13%. They have some self-funded clients. Most of those self-funded clients are bundled with Blue Cross, United, Cigna, Aetna. There's a couple of reasons for that. Maybe the reason that we hear a lot is, it's my employees have one vendor. They can go show their Blue Cross card. They have nothing to worry about. A lot of broker consultants maybe are trying to dip their toes in this arena of self-funding, and so that fully insured carrier is going to make it easy by bringing that packaged approach. The other thing that we see that isn't in the best interest of the client is that fully insured carrier is paying a large override to that brokerage. So that brokerage is steering their clients to fully insured or to self-funding with a ASO, Administrative Services Only approach, with one of these BUCA insurance companies. Cigna Level Funded would be an example. Cigna was really one of the first to the market with a level funded approach, and it's a great product to help a client transition into a self-funded arrangement. And it's easy for the broker consultant because Cigna basically does everything for you. So then the last category is the broker consultant like SolV and like others that we know, and a lot of you are on the call, the Crusader, that's probably about 2 to 3% of the brokers out there, with an inner working knowledge of these alternative approaches, reference-based pricing, direct contracting, and pharmaceutical approaches, transparent pharmacy, 340B pricing, international pricing of drugs, patient assistance programs, and coupon copay cards that can cut a client's drug costs by 55 to 65%. Steers to high quality providers, direct primary care, member advocacy, stop loss protection, integration, so that broker consultant that really has the knowledge of all of those different pieces that are important for a good self-funded plan. So here's
Hey,
some,
Scott,
yeah, got a
going
question?
back, well, maybe your slide gets into this, but looking back at this picture here, you got 2% of folks in the Crusader category. I mean, I think I know the answer, but why do you think there's so few focused here?
Yeah, several of us at SolV have come from large national brokerages, and one of my people, she's been doing this a long time. She was working with a traditional brokerage that was probably in the safe consulting or easy button category, and she joined Health Rosetta. And when she joined Health Rosetta, she started learning about all these strategies, and she brought these strategies back to her brokerage, and they didn't want to walk away from, in their case, the blues and the blues overrides that they were receiving. So as she went back to leadership and said, "Hey, I'm learning these things. I want to, promote this. I think we should be doing this for our clients." She got a lot of pushback from upper management at that brokerage. We're really not interested in this. So I think that's a major driver at the upper levels of the brokerage and management. Um, I know a lot of the vendors, a lot of you on this call that I talk to say that when they call on brokers at the large national brokerages, they often don't get a return phone call. When we go to these disruptor events, I don't see a lot of the top 10 brokerages on that list. I know there's some of you from those top 10 brokerages that are on the call today, but as 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 you look around when you attend these type of events, you probably don't see a lot of your fellow broker consultants from your large national brokerage at those meetings, on those calls. And it's because it's not being promoted from the top down because those large brokerages don't want to walk away from those overrides.
Yeah. Do you have any idea what percentage of the total self-funded space the 2% of Crusaders are touching?
Mm,
For me,
that's a great question. You know, I think if you look at self-funded clients, maybe under 2,000 employees, it's a growing uh, it's a growing market share, but it's still a small percentage. And
a lot of green space out there. I know. But
a lot of green space.
I mean, we've seen and hear the stories of that. The Crusaders, you know, taking business away from the status quo brokers that are out there. I know it's tough to get in sometimes, but once you open the eyes to the CFO of the potential savings, and if their status quo broker is not even mentioned this as an option, I think you found your honey your honey hole there, because
Yeah.
they're wondering why has no one at least explored this, these different strategies with me.
Yeah, and that's a great point, Heath. Something that we hear from prospective clients all the time is they have this perception that things are really broken and they don't understand, why one of their employees or maybe even they themselves went to the pharmacy and their Blue Cross card, the cost of that drug was a lot more than a GoodRx card, for example, or that MRI that was, billed at $5,000. Things like that. Like they know it's broken, but their broker is not connecting the pieces for them. So when we talk to them, they have this aha moment, like, I knew it was broken, and now you're helping me understand why it's broken.
Yeah. Okay, we got a couple questions. Well, here, I know you've got one more slide, so I'll save these questions to the end of this, and I think our timing is in good shape here.
Okay. So some questions to ask your broker consultant. What percentage of your clients, your service team, not the national brokerage, are using RBP? how many RBP vendors does your team work with? So how many RBP vendors is the brokerage or the team representing? What year did you implement your first RBP client? So are they new to this market? And a lot of times if you ask your broker this, they may not have any RBP clients. And so those of you that are on the call that are broker consultants, these are some things that you could work at having good answers for these questions. Is the TPA bringing all of the pieces to the table, or is the brokerage team bringing the pieces to the table? So am I just going to a TPA and letting them choose the RBP vendor and the prescription benefit management company, the PBM? Or is the broker really the expert on those things and bringing those things to the table? So that's my last slide. Let's open up to some questions.
Yeah. All right. So we've got a couple that have come into the chat function. One is about kind of the combination, and some TPAs offer this themselves. Sometimes the broker pairs the concierge medical management with the TPA. But the question is, this individual's kind of had a program that's been a little bit clunky when it comes to those two working together. Any recommendations or thoughts on concierge medical management and how it blends with the TPA and RBP vendor?
Yes. Yes, this is an area that can be a big speed bump to RBP. So a lot of TPAs have their own concierge medical built in, and some are good at it and some are not good at all. So if you're gonna go with the concierge service of the TPA, do your due diligence, talk to references. Again, this is where it's important to belong to a group like Health Rosetta, a group of market disruptors that will have familiarity that you can bounce those questions off of. Or there's several independents out there that you can bring in and couple with the TPA that can handle that concierge piece. We have had better experience with independent concierge services that we've brought in. We have had TPAs that have had their own in-house that we've had good experience with, but we've had more that we've had bad experience with, and we've either had to move TPAs or we've had to bring in an independent concierge service. But it's a critical piece to a successful RBP program, having a high quality concierge that can really smooth the bumps that are inevitable in RBP. A great question.
And the only thing I'd add to that is, different vendors in a stack, whether it be TPA, medical management, the RBP vendor, have different approaches to working with folks in that same stack. So, our approach has always been to accommodate and to customize. Not everybody has that same model. So I think those would be good questions to ask as you go out and explore these things. Okay.
Yes.
I'm going to summarize this one because it's a little bit lengthy, but basically the premise is a lot of times we've got employers that are spread, across the country. You don't have everybody in one location for an open enrollment meeting. Any strategies that you have found to be successful for educating members, whether it be, I'm kind of expanding on this, whether it be in that OE setting or ongoing, to keep folks educated and engaged in the RBP setting?
Yes, that's a great question. A very critical piece to a successful RBP program is employee education. And just like, we talk to a prospective client and kind of give them that righteous indignation with the broken healthcare system, you've got to kind of stir up that same righteous indignation with the employees. And they typically get it because they're experiencing the healthcare system and they're experiencing all these issues that we just talked about. And so the high utilizers are going to be your biggest potential issue, and they're the ones who are experiencing the brokenness of the system the most. So if you can turn that high utilizer into a crusader through your open enrollment communication, then they're going to be more likely to understand the issues that they run into and be patient as the RBP vendor, the third party administrator, the concierge, try to work through those issues. So if you don't do that education, if you just go in there and roll this out and don't really educate members on what they can expect and what a balance bill is all about, and if they experience a balance bill, that they're not going to have to pay that balance bill, that there is help. If you do that education up front, you will alleviate a lot of issues. And most of our clients who have moved from BUCA to RBP in the first year, they have had access issues, but we're generally able to work through those access issues in the first 6 months and definitely within the first year. And they have very few access issues after that. Once we kind of get a provider educated, and typically it's a physician, but once we get them educated on how the reimbursements work, the front desk is no longer turning people away saying we don't take your plan. But that's a critical piece, is that communication. Another critical piece is having the client give something back. So this approach saves our clients 30 to 40% on their healthcare costs. So if your client is just going to take that money and run it to the bottom line and not give anything back to their employees, they're not going to be happy when they run into some bumps. So our clients, we strongly encourage them, give something back to your employees. We had a client that lowered their high deductible health plan deductible from $3,000 to $1,500. We had another client that gave their employees a pay raise, lowered their contributions, offered prescription drugs, a list of drugs at $0. Somehow you've got to give something back to your employees to show them that when you fix this broken healthcare system, it's going to save them money. So that would be my advice there.
Agree. One of the things that we find as an organization that we're continually working through is the game of telephone. You've got a TPA or medical management or the advisor, and there's information that is shared with those individuals, and a lot of times you're relying on them to get that message back to the plan or the member, and just making sure that the message is accurate. And one of the things that we've done this last year is develop our own member app that allows kind of direct access, for submitting an access issue or managing a balance bill. Now, not everybody wants us to have that direct access, so that's customizable as well. But it is something that we've done that I think has done a really good job of giving that member quick access to our concierge team to submit an access issue so we can resolve it.
Yeah, that's awesome.
Okay, we've got 1 minute left. Another question came in. Do you have a go-to for a wellness program that you suggest?
No. Next question.
All right.
So, we've had a lot of clients do a lot of different things on wellness over the years, and we've had clients that have eliminated wellness because the money they were spending wasn't providing a return. I would say my approach to wellness and our approach to wellness has been the best wellness coach is a physician, and direct primary care, that's going to yield the highest ROI as far as money to put into wellness, because you're going to have that physician advocating for the member instead of a health coach who's trying to get a hold of the member, or an internet approach where they're basically going and doing something online that they're unlikely to do. So that'd be my feedback on wellness.
All right. And I know there was another question that came in. Somebody was asking about Health Rosetta. And if we go forward a slide, we'll actually be having Dave Chase of Health Rosetta on Fireside Chat here May 21st. So opportunity for those individuals curious about it to join us on that one. But with that, Scott, phenomenal job. Enjoyed the conversation. Audience, appreciate the participation as well. So enjoy the rest of April, and hopefully I'll see you all back come May 21st, if not before. So thank you, guys.
And everybody, feel free to reach out to me if I can answer any questions for you or help you in any way.
And happy birthday, Scott. Enjoy the week. Yeah. Bye, everybody.